Hi guys, welcome back. Today we shall be talking about dengue virus, which happens to be one of the most common arthropod or arbovirus, which happens to be infecting human beings. Approximately 50% of the world population is exposed to this virus, including developing countries like even Singapore. Then I would say a lot of countries in Southeast Asia, which are economically well off as compared to India, are suffering from multiple outbreaks of dengue all through the year because it obviously rains heavily, and especially in those countries where the urbanization has suddenly taken up, the incidence is shooting up. So the textbook says that about 3 billion people in 112 countries are exposed to dengue virus. And why we are studying about this virus, which is having four serotypes, 1, 2, 3, 4, and is transmitted by Aedes mosquito, is because of the mortality rates. The mortality rates with dengue fever are always usually less than 1%, but if a patient is having severe dengue, I'll be explaining the definition of dengue fever and severe dengue to you today. Then the mortality rate can approach about 5%. But if it is undiagnosed dengue, if there is no support given in the form of either crystalloids or colloids or platelet transfusions if required, then in undiagnosed dengue, the mortality rate can approach as much as 20%, and that can be big setback to any government per se. So I said Singapore is one of, in Southeast Asia, one of the most developed countries, but even then there you do have outbreaks of dengue, and though they launched the dengue vaccine also, but it was recalled due to reasons I'll explain to you, especially in Philippines. So dengue vaccine, which was launched, is a quadrivalent vaccine, as you are aware of, but it had to be recalled due to the fact that the people who have been immunized, if they get infected with dengue, because the immunity is not 100% perfect, they tend to have a dengue that is more severe than what they actually get if they had not taken the vaccine. So we will talk about multiple such issues today, but I just wanted you to be aware of especially the scope of the disease and why it is being asked in the exams nowadays. I also want you to remember that the incubation period for this particular disease after the person is bitten by the mosquito ranges between about 3 to 14 days. And for how many days is the person infected to the mosquito? Like if I get dengue today, then I can transmit it to my family members, because obviously there is Aedes mosquito in my house that can bite my family members and they can get infected. So person is infected to the mosquito for something in the range of 4 to 5 days. And I also want you to remember that the upper limit for infectivity is approximately 12 days. So since they usually ask about these, atypical data, I thought I'll just speak about it. Now, we should be, understanding the fact that why dengue is being asked in the exam. So I'll obviously give you the definition of dengue, which is very straightforward. I mean, anybody living in endemic areas having fever, which is associated with multiple things like nausea, vomiting, rash, or retroorbital pain, or development of positive tonic test, we obviously are going to think in terms of dengue. But in the exam, they're basically asking about warning signs with respect to dengue. So that is the first thing that we will consider. So whether you want to call it dengue or dengue, that's up to you. But the bottom line is, what are the warning signs? So here I have a moribund child with dengue who's admitted in my hospital. Well, the first and the foremost thing that is of concern to me, why I'll say the warning sign is present, is that the child's sensorium is not normal. So if the child is very restless, or the adult is very restless, or there is a obtundation, that the patient is not opening his eyes, that's definitely a cause of concern, because maybe the perfusion of the brain is lesser, because patient is having loss of fluid due to capillaries which become leaky in dengue fever. So you have a third space loss. I mean, dengue fever, why do we say it is dangerous, is because of the fact that there is loss of fluid across the capillaries. We have a lesion called as capillaritis. That's the main reason for third space loss in these patients. That will explain why you are going to have ascites in a patient, pleural effusion in a patient of dengue, and you have then development of shock in the patient. So the underperfusion of brain will occur. Do remember the fact that complications in dengue usually start occurring when the fever is on a declining trend, and the duration of fever is about 2 to 7 days. So when the fever tends to decrease, that is when the critical period starts, and that is when the complications will occur in a patient. So one of the warning signs is obviously underperfusion of the brain, that is restlessness. Then this child could be having maybe bleeding from the nose. So if I go down from the brain, then I need to think in terms of possibly a mucosal bleeding. That could be bleeding from any area, but epistaxis definitely is a cause of concern. The next thing that I need to check up is whether the patient is having very severe vomiting. So I'm going up from top to bottom, right? I mean, they could be CNS issues, they could be nasal bleeding, they could be protracted vomiting in the patient. This vomiting will obviously contribute to fluid loss and development of signs of dehydration, which would be like dry oral mucosa, cold clammy extremities that would be developing in a patient. Now, if we go down, then the problem would be with respect to the lungs of the patient. What's going to happen with respect to lungs is that these patients could be having is a development of pleural effusion, which could be bilateral and could be of the severe variety, or could be, I would say, massive effusion. This will explain why there is breathlessness in patients who are having dengue fever. Then if you go down, we can talk about aspects related to the liver of the patient. There could be enlargement of the liver of the patient. The enlargement of the liver would mean hepatomegaly. So if you find a MCQ or a patient who's having a liver which is 2 centimeter BCM, that means below the costal margin, that's obviously a cause for concern. And then there could also be ascites. So third space loss, both pleural effusion and ascites will contribute to abdominal distension in the patient. Along with this, I said one of the lesions that is seen on defervescence is capillaritis, due to which the fluid is leaking out. So if the fluid will leak out, it will result in hemoconcentration in the patient, due to which the hematocrit of the patient will begin to rise. In fact, one of the tests that tells you that the patient is having a dengue shock syndrome is a rise of hematocrit about 20% above the baseline admission value. And then obviously thrombocytopenia is a cause of concern, with especially platelet count less than 10,000 is where spontaneous intracranial bleeding can occur, and therefore there could be a presentation of CNS bleed in a patient that can contribute to death. So I have today explained to you the important 7 warning signs for dengue, and let's just practice them again, because in the exam they're mainly concerned about are you able to pick up a patient who's really sick, because it's after all a self-limiting illness, so most patients will recover. But the 7 warning signs starting from top would be underperfusion of brain, bleeding from the nose, continuous vomiting, problem with lungs, pleural effusion, and a liver which is becoming bigger, that is a hepatomegaly, then a development of ascites and increased hematocrit and a thrombocytopenia that could be developing in a patient. So the first slide, I just want you to remember these baseline data that I have explained to you, and obviously we will next talk about case definition of the disease. So when do we say clinically that patient is having dengue fever? For this to be present, along with fever, there should be certain things that should be present. One of the very highlight features that you would have noticed would be pain. Now, where would the patient say pain? Or retroorbital pain. I mean, I've had patients who have said that I feel as if somebody is boring into my eye, I feel somebody is drilling into my eye, or retroorbital pain, the kind of pain that you read with cluster headache, or the kind of retroorbital deep-seated pain that you read with glaucoma, that kind of description can be given by patient. The muscle pain in the patient is so bad that person will have difficulty in going to the washroom also. So you would have read about PSM paper saying breakbone fever, which is just to highlight the fact that patient will require support on walking. And when you ask him, I mean, are you so bad and are you so sick that you can't even walk to the washroom? The patient might say that I feel as if somebody has beaten me with sticks all over my body. I feel as if all my bones are broken. So breakbone fever. The second thing that I notice in patients, and that you will obviously see in case definition, would be protracted nausea and vomiting. That's mainly because of the viremia component which is present in the patient, and that explains the dehydration that would be present in the patient. So aches or aches, pain, body pain or joint pain could even be a possibility, but most of the time it is musculoskeletal pain with nausea, vomiting that would be present in a patient, and then you would obviously be having a rash. You see, chikungunya, there is an appearance of a hyperpigmentation that occurs post recovery from chikungunya. I'll show you an image for post chikungunya hyperpigmentation that has been asked in the exam. But yes, I want you to remember the fact that in dengue you have rash appearing at the time of illness. In chikungunya we usually have a post recovery hyperpigmentation, which could be described as a rash in the multiple choice question, and therefore rash could be a feature that could be encountered with both of them. The fourth feature that you will notice would obviously be warning signs that I have explained in the previous aspect to you, ranging from a life-threatening bleeding to development of pleural effusion to ascites in a patient. Then is a positive tourniquet test. For performing a tourniquet test, you will be applying a BP cuff in the arm of the patient and inflate it to mean arterial pressure. That would be a value between the systolic and the diastolic blood pressure, and keep it there for 5 minutes. And if there is appearance of fatigue, that's obviously a cause of concern. From your PSM classes, you would also be aware of the fact that if you have more than 20 fatigue, per square inch of the skin of the cubital fossa, that's definitely a positive tourniquet test in a patient and indicates that it's a cause of concern. And then there would be a development of leukopenia in the patient. The TLC of the patient is low, so just like you are comfortable with the fact that leukopenia is found in typhoid or in even in brucella, you can be having leukopenia even in dengue fever. So there are total of 6 features which are associated with fever in any patient living in a endemic area or has traveled in an endemic area. And as I told you, I mean 112 countries in the world are having exposure to dengue, and I mean 3 billion people, almost 50% they say of the world population can be affected by dengue. Obviously, I mean that's epidemiologist's projection, but the point is that this is the number one or most common arbovirus illness. So person living in endemic area is having presence of fever and 2 out of 6 features that I mentioned before you. So it is fever and any of the 2 features of the 6 features which have been described before you is the case definition for dengue. So let's just quickly revise it here only. I mean, along with fever, what could be present? Muscle aches could be present. There could be obviously puking because of the viremia component, a rash present on the body, maculopapular. Then could be warning signs which are explained on the previous slide, 7 of them. A positive tourniquet test and leukopenia is a case definition for dengue. Let's have a look at a couple of images here. One, I just wanted to show you the rash that is found in dengue. I will like to highlight the fact, and I've said it already, that when the fever begins to come down, that is when we use the word defervescence, that is when the fever begins to reduce. The duration of fever in dengue is about 2 to 7 days. So when the fever is beginning to come down, that is when the critical period will occur, and critical period means that patient can develop complications. What are the complications that you have to look for? One can be dengue shock syndrome, one could be dengue hemorrhagic fever. For dengue shock syndrome, what test will you do? Your answer will be hematocrit. The hematocrit of the patient will keep on increasing because there is loss of fluid across the capillaries. In dengue hemorrhagic fever, obviously the platelet count of the patient will show a serial decrease. I will talk about the serological diagnosis of dengue in my subsequent slide, but at the moment I just want you to be clear about the fact that for the complications which are usually asked in the exam, my here discussion is more focused on the complications part that rather than focusing on the dengue word per se. So hematocrit and platelet count is obviously to be taken into consideration in the patient, and if a person is having bleeding, the hematocrit will begin to fall. So this image definitely shows the presence of a rash of dengue. But on the right hand side I have shown an image where a person is having this darkening of skin, especially over the bridge of the nose of the patient. Initially, if I get an image like this in the exam, I might think it is melasma. Without any history, I might think it could be melasma in a woman, but if there is a history given of a viral infection which is associated with severe joint pain, the patient is recovered, and after recovery, post-recovery, after let me say 2 weeks of recovery, there is a development of this hyperpigmentation, especially over the bridge of the nose of the patient, then we are talking about chikungunya. So do remember the fact that a straight MCQ, which shows an image like this, is obviously to be answered as melasma, but if not, if it is given with a history as they have asked in the exam, post-viral infection, joint pain, recovery after 2 weeks, hyperpigmentation, that would be a post-chikungunya hyperpigmentation that is encountered. Also, I've shown you an image with respect to a positive tourniquet test. You have to inflate the BP cuff to something between the systolic or diastolic blood pressure, or we can say that we can increase it to mean blood pressure. Mean blood pressure is taken as systolic plus 2 times diastolic, whole thing divided by 3. So you have to keep the BP cuff inflated for 5 minutes, and if there is presence of more than 20 PTK per square inch, it indicates capillary fragility. It definitely indicates the fact that there is a definitive cause of concern for this particular patient, because there is a thrombocytopenia which is occurring in the patient. Now you can definitely notice the PTK in the both arms of the patient, especially marked area. There is especially the visible bleed can be seen. But I would just like to show an image in which a BP cuff has been shown in the arm, but you can notice that this diagram is not showing you any tourniquet test. It is rather showing you presence of Trousseau sign. So if they give you an image-based question in which a BP cuff is shown in the arm of the patient, then there could be 2 possibilities. One, he might be talking about a routine tourniquet test, or he could be talking about Trousseau sign of tetany, where there is a presence of a very characteristic carpopedal spasm. This is a feature that can be seen in patients who had post-thyroid surgery, or they can be seen after patients who would have a massive blood transfusion, which can contribute to citrate toxicity, contributing to tetany. So these are some miscellaneous aspects which I want you to remember, especially the images that have to be remembered. Let's look at the subsequent data. You see, when will you say patient is having dengue, or when will you say patient is having severe dengue, is what we need to learn. So let's add a slide here and learn regarding the manifestations of when would you say patient is having severe dengue. You see, one is dengue without any warning signs. That's the routine dengue fever that you will encounter in your clinical practice. You will say that this patient belongs to category A and needs a OPD based treatment. So the intervention that you will do in the patient, I'm just writing the word IN, that means intervention you will do in the patient will be a OPD basis treatment. But if you're having a patient of dengue with warning sign, what I mean by warning sign is presence of the features that are set from top to bottom, ranging from CNS hypoperfusion to life-threatening bleeding, then warning sign present in a patient, then he will be classified in category B and IPD-based treatment would be given to the patient. There's also a possibility that dengue patient is not having a warning sign, but the patient is having comorbid risk factors, or rather I would say presence of risk factors. Now, what are the risk factors that I'm concerned about? One, if the patient is, let me say, an infant, or is a geriatric age patient, or is a patient of diabetes mellitus, chronic renal failure patient, or is receiving steroids, then these are patients who would be classified as category B patients, and they definitely need to be treated on an aggressive basis or IPD basis treatment, because the morbidity and the mortality in these groups would be relatively higher. So for category B, I need to remember two things. One is dengue with warning symptoms. Second is no warning sign present in the patient, but some risk factors are present in the patient, like young age or pregnancy, etc. Then it's definitely a cause of concern in the patient. Now, what do you mean by the word severe dengue? Then meaning of the word severe dengue would be, one possibility is patient is having plasma leakage, that is capillaritis, with fluid loss, which is contributing to patient going into shock. It could be hypotensive shock, it could be compensated shock. What I mean by hypotensive shock is BP is unrecordable. If I say hypotensive shock, it means unrecordable blood pressure. If I say compensated shock, that means BP is recordable. So if there is a capillaritis and fluid loss, that is definitely a feature of severe dengue in a patient. Another possibility can be that the patient is having fluid accumulation. This could be occurring in the pleural space, or it could be fluid accumulation in the peritoneal cavity, and the patient is having a presence of respiratory distress. So severe respiratory distress in a patient is definitely a cause of concern and is again a category C. Then could be severe bleeding in a patient. The severe bleeding is again contributing to hemodynamic instability, and the blood pressure of the patient is falling, resulting in obtunded state in a patient. Cold clammy extremities present, that's again a instability of the cardiovascular system is a cause of concern. And presence of organ failure, it could be a single or a multi-organ failure, like urine output is not there, that's obviously a cause of concern. So the patients that I have mentioned inferiorly, I'll repeat them again. One is plasma leakage with fluid loss, that is third space loss. They could be respiratory distress, they could be bleeding contributing to BP being lower, or organ failure. Then we say category C, and aggressive inpatient care and fluid resuscitation is required for the patient. So first of all, you need to remember this categorization, especially with respect to category C that I have mentioned before you. We will practice category C quickly once again. The basic point is hemodynamic instability is occurring in the patient. And I would also like to clarify the word. One is compensated shock and hypovolemic shock that I was saying. So when will I say compensated and when will I say hypotensive shock in the patient is based on the following information. If in a multiple choice question you read that the patient is having a thready pulse, I mean, you can feel the radial artery or femoral artery in a child, that is a thready pulse, then it is compensated shock with presence of postural hypotension, which means that if you will make the person suddenly sit up or stand up, then the person will start feeling dizzy and might lose consciousness. But if there is an absent pulse and the BP of the patient is unrecordable, then I will say hypotensive shock occurring in a patient. So because the treatment for both of them will vary in the sense that if it is compensated shock, I'll obviously give fluid to the patient, but hypotensive shock, I might have to give bolus fluids and even colloids to the patient. So aggressive treatment is required for hypotensive shock. I mean, treatment is aggressive for shock obviously, but the grading or severity of I would say the aggression with which you will treat the patient will definitely vary with respect to hypotensive shock as compared to compensated shock. So these are the three gradings that I want you to remember. Then we have to study what are the don'ts which are supposed to be done. So this is like three groups, group A, group B, or category A, B, C as they say, with respect to management of the patient that I've explained to you. And then what are the don'ts? Don't use corticosteroids, that is one. Obviously, in viremia, I don't want to take any risk of steroids, and steroids can increase the risk of GI bleeding also. So obviously it doesn't make any sense. Don't give platelet transfusions for low platelet count. As I said, platelet count, if it is less than 10,000 without bleeding or less than 50,000 with evidence of bleeding, then we definitely need to be concerned. But platelet transfusions are not to be given just because platelet count is, let me say, 70,000 and patient wants it, because you see it's an autoimmune process. You give platelets, they're destroyed by the immunity. Half normal saline is a MCQ statement. Which fluid is given in management of patients of dengue shock syndrome? Then the fluid that is preferred is normal saline. Another fluid we can give is ringer lactate to the patient. What fluid is not given? Then half normal saline or N/2 saline is not recommended. This is because this hypotonic fluid tends to worsen the pleural effusion and ascites. It tends to worsen the third space loss. In fact, if you have attended the CNS discussion, then I would like to say the fact that even in raised intracranial pressure, I had raised this aspect that 0.45% saline is not given. So there are in fact now two conditions that you are aware of where you don't give N/2, that is half normal saline. One, you don't give it in patients of raised intracranial tension, and second condition where you don't use it is patients of dengue shock syndrome. I'll just enumerate both of them simultaneously. Raised SAT and dengue shock syndrome are conditions where you are not supposed to give N/2 because of the worsening of the cerebral edema component and the worsening of the third space loss in the patient is the reason why you would be having problems in the patient. Okay, let us now look at what are we going to do if the patient is in group A or category A for management of a patient of dengue fever. I'll obviously wait for defervescence and make the patient be aware of the critical period. So one of the important things is that when the fever comes down, that is around 2nd to 7th day in dengue, depending on the serotype that has infected the patient, there are 4 of them, then awareness of critical period on both the part of the physician and obviously on the patient's part is important, because that is when he knows that he needs to see you. One of the important things where a patient has to be managed and be aware of is dehydration present, because continuous vomiting and fluid loss from the patient can cause this person to deteriorate from DF to that of DSS and dengue hemorrhagic fever, which could be present concomitantly. For dehydration, well, in children you are aware of the standard features like sunken anterior fontanelle, sunken eyeballs of the patient, or dry oral mucosa. These are standard things that you study in pediatrics, cold clammy extremities. So the same features that you study in dehydration and diarrhea, the same things are to be considered in this particular case also for both children as far as for adults also. And dengue, you would have seen that it's more severe in urban India, less as compared to rural India. Why that is so is because you see in malnourished children in rural India, the ability to fight against the infection itself is not there. So the severity of disease is lesser. And in urban India, because obviously people are relatively well nourished, they are able to launch a more, I would say, aggressive antibody response to the virus. So the virus also hits back more aggressively, and therefore the disease severity is more in, I would say, upper socioeconomic, and people who are rather well nourished tend to have a more severe dengue as compared to malnourished people. So presence of dehydration should obviously make you consider admitting the patient and giving fluids. So dehydration evaluation is to be done first, and patient has to be made aware of the fact that if there is a decreased urine output, or if there is a dry oral mucosa, or there is absent tears in a child on crying, then these are situations where the patient would be brought to the hospital. For control of fever, paracetamol is obviously to be used, that is 6 hourly, and not more than 4 dosages to be used. And you would have seen that most of the time by using paracetamol the fever does not come down. So tepid sponging with cold water can be done, but not chilled water, because that will make the patient feel very uncomfortable. COX-1 inhibitors are obviously not to be given. They will interfere with the platelet function subsequently, so do not use COX-1 inhibitors in the patient, because the patient will be infected to the mosquito for next 5 days. So insect repellent can be used on the patient so as to make him non-infected to the mosquitoes. And obviously steps should be taken to destroy the mosquitoes in the house, or discard any I would say containers that might be having some water. If there's a money plant in the house, the water in that might have accumulated, that has to be discarded. So obviously some basic steps that you study in PSM are to be taken care of, and the patient has to be told that he has to follow up with you when the fever is beginning to decrease. Now, what will you monitor the patient for? Then you will monitor the patient on arrival in the critical period for CCTVR. What is CCTVR? You will check the color of the patient. What I imply by color is like there could be cyanosis occurring in a patient, or there could be just a, I would say, pallor present in the patient, pale patient. That's obviously a cause of concern. Then I will check for capillary refill time for circulation. To check for capillary refill time, you can use a thumb and press on the forehead, or you can press on the sternum of an infant. Then capillary refill time, normally it is less than 3 seconds, but if it is more than 3 seconds, then it is definitely a cause of concern, especially for infants and small children. T would stand for body temperature. So if there's a hypothermia, cold, clammy extremities, as I'm saying, with in shock, that's a cause of concern. Then is the volume of the pulse and rate of the pulse. By volume of the pulse, I mean whether pulse is felt or not, or there is a thready pulse. And then is obviously the rate of pulse, because if there is a tachycardia, that is obviously one of the early signs of presence of shock. So monitor the patient for CCVTR in the critical period, and you would be able to make a decision whether patient requires any fluid resuscitation or not. Now, assuming the fact that the patient is going into features of group B or category B, what I mean by group B or category B is the presence of the warning signs that were discussed right in the starting of this discussion, just to remind you. Or for that matter of fact, there could be presence of risk factors in the patient, like it's an infant, etc. Then in those circumstances, the inpatient management is to be done. And what will you do in inpatient management would be vital monitoring, that is to be done 4 hourly. You will also be going in for input-output monitoring, so that you can check whether there is a development of shock in the patient or not, because if the output, urine output is reducing in the patient, then that's definitely a cause of concern. So in my patient in group B, there are presence of warning signs, the BP is on the lower side, patient is attended. So what I will do in the patient will be, first of all, I will start the patient on crystalloids. The preferred crystalloid to be used in the patient is normal saline, then is ringer lactate. How much would I give? I would give in the range of 5 to 7 ml per kg per hour for the next 2 hours to the patient. Then I will slow down a bit and give it at a rate of 3 to 5 ml per kg per hour for the next 2 hours. Once 4 hours are done, I will re-evaluate the patient again. On re-evaluation, there can be only 2 possibilities. One possibility can be that the patient has improved or he has not improved. Now, how would I know patient has improved? Then the hematocrit of the patient, I'm writing a short form HTC, is improving. What I mean by hematocrit improving is that earlier it had increased by 20%, now it is coming down from a 20% increase to 10% increase. That means hematocrit is improving, and the clinical features of the patient are also improving. So that basically means the fact that I can reduce the amount of fluid that I give next to the patient to on the lower side of, let me say, 3 ml per kg per hour for the next 4 hours. And because my patient is now responded, I will gradually switch to oral fluids. So wherever possible, as there is a hemodynamic improvement of the patient, you should try to promote water intake and switch to oral fluids in the patient, and obviously keep the patient in the hospital for next 48 hours before you plan a discharge for the patient. We'll also talk about indications for discharge that were asked, but at the moment I just want to highlight that if the patient is improving, the hematocrit of the patient will start coming back towards normal. But the second possibility in the patient can be that the hematocrit of the patient is increasing even further. Like there was a 20% admission over the baseline, increment over the baseline. Now it's increased to 25% over the baseline. So, and the clinical features are also worsening. Like when the patient came, he or she was opening his eyes. Now the patient is not opening his eyes. So that is definitely indicative of deterioration of the patient. So that's definitely a red flag and I need to be worried about. So what I will do in this patient will be that I have to give straight away IV fluid. And how much IV fluid will I now give to the patient would be a little more, that is about 10 ml per kg per hour for the next approximately 2 hours. If you evaluate the worsening scenario in the patient, you will notice that when the patient came, I gave about 5 ml initially for 2 hours, 5 ml again, approximately 3 to 5. So another 5 ml for another 2 hours. So 10 ml was given in the first 4 hours, 10 ml per kg per hour. Now I've added another 10 ml per kg per hour for 2 hours in the patient, and I will reevaluate the patient again. When I reevaluate the patient again, there can be two possibilities on this side again. One can be that the hematocrit of the patient has begun to reduce. Now this is a cause of concern because hematocrit was earlier rising, now it is falling. Why it is falling? Because the person is having bleeding. It could be visible external bleeding, it could be internal bleeding in the GI tract of the patient. So if the person is having a fall of hematocrit here, bleeding, you will obviously have to give packed RBCs to the patient, or you might have to give blood transfusion to the patient. But on the other hand, let me say the hematocrit of the patient has not become lesser than normal but has risen even much more. So I'll put 3 arrows just to say that the hematocrit has shown a further spike. This definitely means the fact that this is time to be a little more aggressive than what we were initially, and we will be giving a bolus to the patient. We will be giving 2 boluses to the patient, and depending on the recovery to the bolus, we will then decide the next course of action. Bolus 1 is usually given at 10 ml per kg per hour, but this has to be given over 1 hour. So do get my points right. Initially I had given 10 ml per kg for 2 hours, now is over 1 hour. If there is no improvement, I'll just write a small note here, no improvement. Then I will give bolus 2, that is 10 ml per kg per hour over 15 minutes. So the aggression with which I'm giving the fluids is increasing. You can see the tremendous amounts of fluids that I'm giving to the patient. And at this moment, I would also like to intervene here and say the fact that this particular patient who's having requirement of a bolus is basically a patient who belongs to category C or group C. Why I say group C is because group C is the patient who is the most severe one. He is having 2 types of shock. Either it could be hypotensive or compensated, and the difference between the two would be that in a hypotensive shock the BP will be unrecordable, in compensated BP would at least be recordable. So if a person is having a situation where the BP is unrecordable, let me say, or is, let me say, 80/60, I need to give a bolus shot to at least make it recordable. I have given 2 boluses and still there is no improvement. What am I going to do to prevent mortality? I'm going to give colloids to the patient. Colloids that I can give to the patient is like albumin, or I can use dextran, which is available in the hospital. But the indication for giving colloids in dengue shock syndrome is only when the 2 boluses are not worked. So I'll just minimize this flowchart at the moment and highlight that how did I upgrade from here, and just try to follow the sequence. The monitoring is done on 4-hourly basis. Input-output charting is obviously to be done every shift. The nurse will measure how much is the urine output of the patient. In group B with warning signs where the patient is attended, try to give fluids over the 4-hour period, and if he recovers, great. How do you know recovery? Hematocrit starts decreasing, not less than normal but decreasing towards normal. If it is rising even more than normal, you need to give a little higher amount of fluid, that is for 2 hours. If the BP is now plummeting even lower than this, you need to give bolus shots, and if bolus shots are not also working, then you have to definitely use colloids for the patient. But if there is a fall of hematocrit that is like less than normal, then there is an internal bleeding in the patient, so packed RBCs would definitely be required to raise the hematocrit. Now what is the role of platelets? Well, platelets are only to be used if you are having a platelet count less than 10,000, because that increases the risk of spontaneous intracranial bleeding. And if there is a life-threatening bleeding, let me say, with even platelet count of 30,000, less than 50,000 I'm saying, and there's a life-threatening bleeding occurring with multiple sites are having bleeding, I'll definitely give platelets to the patient. So indications for platelets are less than 50,000 with bleeding and less than 10,000 without also bleeding are the situations where you would be giving either a SDP, single donor platelet, or you would be giving a platelet rich plasma PRP to the patient, that is 4 packs of PRP that we standard give to our patients. Now, this is what I was talking about, guys. Group B patients who would be having a requirement of CCTVR, and if the hematocrit improves, that is great. Otherwise, the fall of hematocrit indicates bleeding, as I explained to you. Well, what are the tests which are available for diagnosis of dengue? Because we were talking about clinicals. You see, in emergency, when the patient will come, you will have to do a clinical diagnosis only. How do you do a clinical diagnosis? Like in city like Delhi, you are having a patient in the after the rainy season with the high grade fever, which is showing a poor response to paracetamol, with presence of nausea, vomiting, presence of a rash, present positive tonic sign, warning symptoms. Then I have to consider dengue fever clinically, and I need to evaluate for presence of shock in the patient. The tests would be available maybe the next day morning. The test I can do in the patient is one, a MAC ELISA, which is the standard capture enzyme linked immunoabsorbent assay available. This test usually tends to become positive by the 4th or the 5th day of the symptoms only. So if a patient comes early, obviously you would not be able to identify presence of dengue, though you have a test by the name of NS1 antigen that can become positive even earlier, but non-structured antigen or NS1 antigen alone is not available for diagnosis. So you will have to base your diagnosis on the basis of presence of IgM class of antibody in the patient. So you will have to base your diagnosis on the basis of presence of IgM class of antibody to the dengue virus. This antibody should show a 4-fold rise in paired sera IgM antibody to the dengue virus, and shows a 4 times increase in the values if you do a paired sera, and obviously the test becomes positive subsequently. Along with this, we can use NAT, that is nucleic acid amplification technology, or PCR. So if the question says what is the ideal way to identify presence of dengue in a patient, then the first answer of yours would be rise of antibody titer. Along with this, we will also check for nucleic acid amplification technology. So the combination of the two would help you in identifying dengue in a patient. IgG antibodies can also be positive in a patient if he has had an infection with dengue earlier, and you would have noticed the fact that if a person has had a dengue earlier, then the incidence or the severity of the dengue this time will be higher than what it was initially. The specimens which are obviously taken are serum and CSF can also be taken. Do remember the fact that we are not going to wait for the results to come to initiate treatment for our patient. So this is all speculative that the investigations would be done. It is a straightforward treatment which is to be based on the categories that I have mentioned before you. Severe dengue is a must know for you from the exam perspective, primarily because there is a fluid loss occurring from the body. There could be pleural effusion occurring, there could be ascites occurring, third space loss occurring in a patient, and if hematocrit falls, it indicates possibility of a bleed. When it comes to platelets in a patient, if you are using platelet rich plasma, then the platelet count will increase by 5,000 to 10,000 per unit. And if you are using pooled platelets, then I can say the fact that with respect to pooled platelets, the risk of allergic reactions or the risk of anaphylaxis will be relatively higher. But if you're using a SDP, that is a single donor platelet, which is produced by apheresis. Apheresis is a machine that will remove the blood components from the body of the donor and will send them back into the body of the donor, except the platelets. Only the platelets will be removed. So when it comes to SDP, the single donor platelet, the chances of allergic reactions will be relatively lesser. So do remember this information, that is, if you are using PRP, which is commonly used in our hospitals, then 1 unit will increase the platelet count by upper limit of 10,000. So that will definitely help you go over the critical level of less than 10,000 that I was saying, where there can be a increased incidence of spontaneous intracranial bleeding in a patient. Now, once the patient is stabilized, you will have to discharge the patient. Whenever you are reducing the fluid that you're giving to the patient, reduce it slowly. Like suppose you are giving 10 ml per kg for every 4 hours, then you can downgrade to, let me say, 7 ml per kg, then 5 ml per kg, then 3 ml per kg. So fluids are to be gradually reduced, and the oral intake in the patient should obviously be increased. So when would you plan a discharge for the patient? When the patient is afebrile for 24 hours without antibiotics. Please be very specific about the word here, because what they did in the exam was they said afebrile for 24 hours with antibiotics. Now, if somebody is taking antibiotics and is afebrile, you will not plan a discharge, no. But if you have ensured that the dengue the critical period is over and now the patient is afebrile after 7 days, at least I'll wait for 24 hours. There is no requirement of paracetamol. That is when I will discharge the patient. Obviously, the oral intake of the patient has to increase because input of the patient will definitely decide the urine output. So input will definitely depend upon the good appetite. That will cause a adequate urine output. What is normal urine output? It is 1 ml per kg per hour. For 60 kg man, it will be approximately 60 ml per hour. So by multiplied by 24, this will work out to about 1500 ml. So good urine flow is obviously warranted in the patient. Stable hematocrit level, neither a rising trend, neither a decreasing trend. At least 48 hours since recovery from shock. That's very logical because you see, at least I want to make him spend as much time in the hospital in the critical period. Critical period itself will last for 48 hours. So the point is, once the critical period is over, when after defervescence I was saying critical period, then at least make the patient stay for another 48 hours after the recovery from shock, and he is on good oral intake, adequate urine output. It's time for discharge. There should be no breathlessness, recovery from pleural effusion, ascites in a patient, and platelet count less than 50,000. So these are the indications for discharge in a patient. And they just played around with English here. These are very common sense things. No, if a person is eating well, he is drinking well, normal urine output, doesn't have fever, and is having a good platelet count, a little more than 45%, and 48 hours have passed after recovery from shock, then the patient is ready for a discharge. The vaccine, guys, is a vaccine that has a strain which was asked. I want you to remember the name of the strain, that is C by D TDV. So a lot of guys, they just picked up this word, no, TDV, and they said we could crack the question. So this is a tetravalent live attenuated vaccine which is to be given in 3 dosages. The dosages are to be given at 0, 6 and 12 months. So 3 shots are to be given to the patient at 0, 6 and 12. And Singapore was the first one to recall this vaccine. Then Philippines followed. So I just took a snapshot from Singapore newspaper which said that they have issued advisories on dengue vaccine. The Philippines in fact has totally, in a knee-jerk reaction, banned the vaccine. Why have they banned the vaccine is because they have found that some people who have been vaccinated, if they get dengue, because the seroconversion rate may not be perfect, so if they get dengue, the severity of dengue is more in patients who are vaccinated as compared to those who are not vaccinated. So obviously Sanofi Pasteur, they had to suffer a lot of economic losses. I mean, I read they had invested something like $115 billion. I mean, huge amount, the number of zeros is huge, and the economic part of this entire, I would say, the health sector was impacted because of the recall of this vaccine. So we still have a long way to go when it comes to handling this particular infection, and I have tried to emphasize mainly on the clinical domains that I would like you to remember for this particular topic. So thank you so much for listening, guys, and keep working, keep hammering. Obviously the wall will break, and it is this time of the year when we start preparing and we are like wondering what is to be read and what is not to be read. So I want you to read everything, give it your best, I would say best that you've got, the best punch that you can deliver, and keep on working on a daily basis, because the little bits of knowledge that you keep on inoculating on a daily basis into your gray matter, the cytokines then start decreasing, the neurotransmitters start increasing, the neuronal flow will increase, so you would be able to retain better, you would be able to remember better, and as they say, practice makes a person perfect. So listening to the data again, or making notes by yourself, or doing hand practice by yourself of whatever you've listened would give you an edge over others. Thank you so much for listening.